Morning and good evening to our panelists. As I mentioned, my name is Dr. Grishma Shah, and I'm the co-convener of National Ability Summit. My training is in community psychology, where I look deeply at how units like family or community work together. And the community that I focus heavily on is entertainment. So, as an entertainment psychologist and artist in Chicago, my work is to make Hollywood and Bollywood more inclusive. I have wheatish skin and very big eyes, at least that's what I tell people. And my hair is in a bun and I'm wearing a green shirt. In 2020, so many of us were impacted by a very small thing called COVID-19, which is not a very small thing at all. And in many parts of the world, it's also known as the coronavirus. Most of us fell into this spectrum. On one side, we were either working from home and having little kids at home, and we're doing the best that we can. And on the other side, we were either first responders like police officers or working in the hospital or a grocery store clerk. We had to physically be at work because we were deemed essential by the government. And we were not able to carry on with our lives remotely, professionally. To make that even more burdensome or more responsibility-ish, people around the world wouldn't be able to carry on with their lives if we didn't do our jobs. And now studies are coming in which are suggesting that the long-term effects of COVID-19 are affecting us mentally. So COVID-19 has surely put a spotlight on mental health, even though it's existed for an extremely long time, which is why at National Ability Summit, we really wanted to dedicate a panel to talk about strategies to enhance access in mental health services. And my co-moderator for this session is Dr. Nimesh Desai, also known as Professor Nimesh, who has 40 years of experience in academia and the public sector as head of Department of Psychiatry and medical superintendent, and has been director for the past decade. Having received national recognition multiple times for original research papers, and if it wasn't enough to have a doctorate, he also went to Johns Hopkins University in 2001 to get his master's in public health, which I also have too, a master's in public health. So next up is Dr. Kv Kishore Kumar, who's trained as a psychiatrist in Bangalore and has worked in community psychiatry for 30 years. He's currently the director of Banyan in India. His areas of interest include community models for mental health care, health promotion using a life skills approach, initiation of community-based detox programs, and my favorite, stress management for lawmakers, among other things. One of his most significant contributions has been to develop life skills manuals for teachers for health promotion of adolescents, which are used extensively around the country. He was also a member of India's first national mental health policy. Next up is Mr. Narendra Kinger, the founder of mental health NGO Talk to Me. He's a practicing clinical psychologist and psychotherapist working in Mumbai, India for the past 34 years. His interest in mental health, coupled with awareness about lack of adequate focus on mental health issues in India and inadequate available resources or facilities of the deprived sections, has propelled him to set up Talk to Me. He's worked in several schools and has done many amazing things. He's also been featured in the Times of India for conducting the largest study on mental health in police on 1,800 police personnel, sponsored by Harvard University. And last but not least, we have Jeff Tate, who is the chief of a city of 43,000 people, which is about 20 minutes from Minneapolis in Minnesota. He's been in the police department for 23 years, being chief of police for 13 years. He has a bachelor's degree in criminal justice and a master's degree in public administration. He graduated from the FBI National Academy in 2007 and serves as a board member of the Minnesota Chiefs of Police Station Association. Jeff is now one of the longest serving chiefs in the Twin Cities area, and as far as I know, has completed at least one program at Harvard University. These are quite some amazing, amazing bios. And with that, I pass the baton to Dr. Nimesh to start our first question.
Thank you, Grishma. Thank you so much. As you said, and I completely agree, this is such an amazing panel across these two major countries, and it's so wonderful to have all of us here together. As you said, we are here to talk about access to mental health care and mental health care services, especially in the context of the epidemic and the post-pandemic era. Uh, and as you said, mental health problems have always existed. That's now come to the forefront. And yet, the old problem of what's technically called the treatment gap, people with significant mental health problems not reaching any mental health service, still remains across the globe, and in India and South Asia and Afro-Asian contexts, much more than the rest of the world. And so let's begin with, shall we, Dr. Kishore, with you?
Yes, sir.
You, please, if you have your initial comments on this entire situation of treatment gap and enhancing access to mental health services, especially in the pandemic and post-pandemic context.
Yes, sir. Thank you, Grishma and Dr. Nimesh for making me part of this panel. Incidentally, Dr. Nimesh is my teacher. When I joined psychiatry, he was the senior resident, and he fondly remembers me for that. Coming to the topic of enhancing access to treatment for the marginalized community. In India, I think it is one of the biggest gaps that exists for nearly 2 million homeless population, of whom a quarter of them suffer from severe mental disorders, which is close to about 500,000 people distributed in this country. In the normal situation, non-COVID situation, there existed no services for these people, except that the police would round them up and take them to the treatment center, which is usually the mental hospital. But a large number of NGOs also did this work for the last 3 decades. The NGO work continues in the most efficient manner, whether it is COVID or non-COVID, but the government facilities became almost redundant because most of the hospital beds were converted into COVID beds, and therefore these people had nowhere to go, and they were the last people to be counted, and therefore the treatment gap was really huge. When the treatment gap for the general population is close to 83%, you can imagine that the treatment gap for the homeless population will almost be 100%. A large number of people continue to live lives of neglect, impoverishment, and marginalization. As a result, these people's mental disability increased, their functionality decreased, and therefore the quality of life is perhaps the poorest. So in such a situation, what are the strategies that is existing which we can think of in a prospective manner? It includes multiple level of things. At the level of cities and towns where the homeless population are found, at least for every 60,000 population, my speculation is there should be an access point where they can seek help for mental health problems or physical health problems. And waiting for them to come and seek help is almost impossible, and therefore there has to be an outreach program for such population. In the Banyan, we have been running what is called the outreach program for the homeless population, providing them food, clothing, medicines if they needed it, or other kinds of access like the voter card, the Aadhaar card, which is necessary for them to access benefits, even provide them housing. During the COVID time, we were able to extend support for large number of people who were affected by the COVID themselves. for those people who were accessing care after being homeless, nearly 400 of them received direct bank transfers, dry ration, which is dispensed at their home, without which they would not have survived. So outreach is an important access point, making hospitals friendly for the homeless people and opening up special wards for them so that they can access care for physical problems, mental health problems is a clear way forward. In the recent past, we have launched what is called as the Emergency Care Recovery Center. For the first time in the country, there are 15 districts which has what is called as the Emergency Care Recovery Center. These people are rescued from the streets, brought to Emergency Care Recovery Center, a value-based, rights-based, person-friendly approach is used to facilitate recovery, and thereafter these people are reintegrated with their families if that is possible to find. We also have in parallel developed a very innovative program for the first time in the country, what is called as Home Again. For those people who cannot return back home, they will be lodged in a house, they live in the community, and this entire construct of care is compliant with the Mental Health Care Act, which is again rights-based approach. Every person has the right to live life like you and me, and therefore close to 200 people in the states of Tamil Nadu and Kerala are living in this context. We are likely to upscale it to about 800 people over the next 3 years. This will be the largest sample ever in Southeast Asia region who will be provided long-term care options in the form of Home Again. And the next one, of course, is to make the district mental health program far more efficient by reaching out to people in the urban locations, because largely urban locations are the places where people with homelessness, people with mental health problems live. And today we have close to about 630 homeless shelters. By no means this is adequate. This number has to increase to large numbers. It has to increase many fold. Moreover, all these shelters should also have the mental health component integrated into their care so that these people receive good care. And the last but not the least is linking all homeless people to housing, social welfare benefits, disability benefits, and other citizenry rights, so that they are able to live life like you and me. These are some of the initial remarks that I had to say for increasing access to mental health care with respect to the homeless population for both men and women.
Thanks, Kishore. Thanks so much. And my apologies for something that Kishore and I missed out, and I request the other panelists to do that as Grishma had advised. The physical description for some of our friends. I'm an athletic, too heavy set, 6 foot tall person who is right now in front of the camera with a pure silver white French beard and silver and black hair on the top of my head with a deep blue shirt. I am facing the camera with a headphone on. And Dr. Kishore, would you please in a few seconds give your physical description for our friend?
I'm a very diminutive man working in adult psychiatry. I am possibly the shortest person in the ward, and continue to work with this population for 4 decades. I am wearing a gray kurta. I have silver gray hair and also a beard, wearing black rim glasses.
Thank you. Thank you. Sorry about that. Problems of being in a hotel room. Okay, Grishma, I must clarify that Kishore and I, besides having traveled together, although in different cities across the large country, have had this common interest in the homeless populations. And Kishore described so well the issue of enhancing access to mental health services for homeless and underprivileged populations that I'm sure we'll add to. But let's switch gears a little and talk to our friend from Mumbai, as you had described. Narendra Kinger, our psychology colleague, who besides his clinical practice has also gone on to launch helplines for enhancing access. And so thereby, it seems to me that we'll actually be enlarging the scope of this discussion to not only homeless persons with severe mental disorders, which of course does interest Kishore and me very much, but to enlarge the scope to all across the population, people with severe mental disorders, more importantly, persons with anxiety or depressive disorders or stress-related syndromes or trauma-related issues. And so, Narendraji, if you'll please share with us not only your experience, but also the larger issues of helplines and how do they work and how we could make them better.
Okay. So thank you very much for having me here, Dr. Grishma, Dr. Nimesh. And it was wonderful hearing Kishore. So by describing about myself, well, my hair is genuinely black. It's not colored. It's black. I'm 60 years old, though I may not look 60 to you, or maybe I look older. I wear reading glasses. I'm wearing a check blue shirt. I've been a practicing clinical psychologist and a psychotherapist for the last 35 years. I started in 1986. So it's been a long journey. And Kishore said he's worked for 40 years. Well, I'm 5 years short of that. About 3 years back, we set up this NGO called Talk to Me, a mental health NGO. The exclusive focus of the NGO is mental health because while working for the last 30 years, I realized that there's a lot of poor people, a lot of students, or a lot of people who come from lower income groups or middle class society who are unable to access counseling services, psychological testing services, or like you, Dr. Desai just said, in terms of anxiety and depression. And they need some kind of a program where actually it's the lack of financial resources that prevents them from actually taking this help. So surely I agree that psychiatry and psychology work as a team, and we kind of complement each other. But in India, we have its own unique problem, which I don't know about the rest of the world. But in India, we find that a lot of people are reluctant now to go to psychiatrists for fear of being on medication, which they feel zombies them out. They kind of feel knocked out, and they feel that it interferes with their day-to-day functioning or their ability to earn a living. Now, when we're talking about people who are already deprived or don't have really resources, they cannot afford to spend one day waiting in a public hospital to seek these services. So they want a kind of a quick fix cure. Now, there's no quick fix cure for mental health. As we all know, it takes a couple of months, years for people to kind of stabilize, feel good, and over a period of time, only when they continue with treatment do they really get the full benefit of whatever services we are able to offer. And I think we offer phenomenal services, whether it's in India or any part of the world. So the whole idea of the NGO was that there are people who, if they are reluctant to go to psychiatrists, they reach out to, this is a first line, kind of, they come to us and we actually sit with them, listen to them, and get them convinced that actually this is a problem where they would need psychiatric intervention or where they need mental health support services. Those, we also have a team of clinical psychologists who do various psych testing, which actually diagnoses the problem. Because the other part is, when we as clinicians diagnose that, oh, you have anxiety or you have depression, people are not really convinced because they really don't know the whole DSM concept that we are following, and they are really looking at something. So when we give them a report on paper, or we actually show them that this is a test which is picking up this, and they go and show it to their family physician or a family member, that's when the community gets involved, the family support system comes into play, and they take their services, they take their mental health issue more seriously. So the idea was that we wanted to create a service where money is taken out of the equation. We don't want people to have money to be able to access. So that was point number one. The second thing is that in India, mental health is seen as a stigma. People avoid as far as possible, and they only come to us when it's absolutely like a real critical juncture. So when we wanted to focus on educating the general mass or creating a kind of a helpline where people can phone in, talk in, get on a video call, have a session and talk about it. So that's the second part of it. And third is we also felt that apart from virtual calls or phone calls, we don't do chat this thing, but we wanted to create a physical space. So we actually set up a clinic, which is a pretty big clinic, going by Bombay standards, of course. And we have 5 consulting cabins with a group therapy room where people can actually come in, be there, and have a physical session. So the idea was to create a physical space and a profile whereby people can reach out and have a session or couple of sessions, so on, and then kind of make them ready to deal with whatever they are going through. I also feel that while we were doing this, we started getting a lot of young students, college going students or young people, and they would call in and say, my family doesn't understand that I'm going through a depression or anxiety, or I have gender issues, or somebody who said I'm finding it difficult to cope up with my academics, unable to concentrate, but my family doesn't support me. So that's when we decided to set up a Instagram page, which is talktome.ngo, where we started having live sessions with psychiatrists, with counselors, and we also started calling people from various walks of society. And we started having conversations around mental health, around challenges, around people, who can kind of band together and do this. So we also, our psychologists put out some reels on common mental health issues. So we are trying to take the whole stigma out of it. Of course, we have some music in the background, which makes the reel very lively because we're dealing with young people. So we want to make it a pretty good platform whereby young people reach out to us. So this is the journey of Talk to Me.
That's so fascinating, Narendraji. Thank you. And Grishma, as you and our other friends who are listening in must have realized, you already have a spectrum of experiences and opinions from some of us who are qualified, trained mental health professionals. I'll only briefly say and summarize that what Dr. Kishore and Narendra Kinger described, in addition to my own experience in the north part of India, would actually suggest that there is doubtless a huge treatment gap across the spectrum of mental health problems and across different strata of the society. And the pandemic, while it has brought attention to the mental health issues, we still have a long way to go in terms of ensuring access to mental health services for at least a large number of people for a variety of mental health problems. We all also realize from experience and learning that all sectors, public sector, mental health institutions to NGOs to helpline services, all have tremendous role. And I'm reminded of what the British say in the context of cricket, that of course is very popular in India. And I suppose that could also apply to the American baseball, different strokes for different folks. But that's as far as it comes, Grishma, from a few of the mental health professionals that we have on the panel. What I'm thrilled about is that you seem to so comfortably and beautifully ride those two horses of academia and the field world, academia in psychology and the field world. And we have Jeff Tate from the entirely different perspective from police enforcement officials getting into mental health services. Can I now request, please, Grishma, for you and Jeff to complement what we have said till now?
Yes, thank you so much, Dr. Nimesh. So Jeff, this point of access and helpline is a very important one. Mm-hmm. And I'd love to get your perspective about how it's being assessed through the lens of first responders.
Well, hello, everyone. And for starters, Jeff Tate, I am a male 5'7". I'm wearing a black sweater today, black hair, what hair I have left. And I'm sitting in my office here in Shakopee, Minnesota. We're a 20-minute drive straight south from Minneapolis, Minnesota, where So much of the world watched the last year and a half after the George Floyd murder. And I'm honored to be a part of and humbled to be part of such a distinguished panel. It's interesting when I listen to what you're bringing up in India, everything you're talking about in terms of access, resources, stigma, plays right into what we see every single day in law enforcement here, just in Little Shakopee, Minnesota, in the United States. And the access to resources is such a critical gap that we have here. Number one, mental health calls are our number one call for service. It's not a slip or a fall. It's not a heart attack. It's not a car accident, somebody stealing something. Our number one call for service is a mental health call. A lot of times that can mean homelessness, that can mean addiction in some form. And we don't have the resources to properly slide these folks to where they need the best treatment option for them. And for far too long in this country anyway, and in this area, the largest housing for people with mental health needs has been the jail. And that is simply not working. It's not appropriate, and it's not where we need to go. And we've recognized that as a profession. Thankfully, over the last few years, have tried to take some substantial corrective action on that. And then, the other part of that too, is the mental health of the officers and the first responders themselves. We talk about stigmas, and for how many generations, my father was a police officer. You didn't dare show weakness, right? You didn't want to show that you needed help. Yet you're seeing bad things happen to good people every single day. You're seeing some pretty bad things happen that you don't maybe take home and talk about or process in the way that you should. And that for so many years and decades has been seen as weakness. And we've really tried to turn the page on that and start protecting first responders more. And one of the things that we've done and regionally in the state have done is a program called Checkup from the Neck Up. We require our sworn staff to go see a licensed psychologist every single year. You get the day off, you're going to sit down, and you are going to empty your bucket with whatever you need to. And it may be a list of calls, it may take an hour, it may take 3 hours, but you are going to go get that help. And you're going to do that a minimum of annually. We pay for 3 follow-up visits if that is something that is required. And we recognize that there's not one treatment, I should say, that necessarily is appropriate for every single individual. So there's a lot of different toolkits that we're working on and we're developing. And why is this a big issue for first responders? Just real briefly here, the Minneapolis Police Department that has been in the national and international news, they've lost 1/3 of their police force to PTSD in the last year. In the last year in the state of Minnesota, 79% of the police officers that have retired have done so with a PTSD designation. 79%. We're missing something here, and we need to fill that gap, and we need to properly address with treatment and recognize that our first responders need help too, if we expect them to help others.
Thank you so much, Jeff. That's so enlightening. And I'm so glad, Grishma, I'm sure you agree. Jeff has, in addition to what Kishore and Narendra had said, has expanded the scope of this discussion to include the mental health of the first responders, be it enforcement officers or mental health professionals or health professionals. But as I said, you seem to have one twin track learning opportunity across films and mass media and psychology. And the other thing is that it seems to me you understand both cultures, India and US, and the local context. And so can we expect you to really see how we can do better about reducing the stigma, increasing access, making people, including first responders, a little less hesitant to seek help from all the various perspectives that you already know?
That's a really great question. With the example of George Floyd, I often tell my clients and other people that I work with to focus more on the police officer. What did this police officer learn as a young child, which made him feel or think very naturally that some people should be treated one way and other people should be treated the other way? And I truly feel that it's because of the stories that we've learned when we're very, very young. There's this book that's called What Happened to You? And in that book, they talk about how kids have their brains developed from 0 to 6. And what happens after 6 is that these experiences get filtered into different pockets of the experiences that they already had from 0 to 6. So imagine like a bunch of folders. So when I'm 20, this experience goes to this folder that I had when I was 5 and vice versa. So we really need to be able to talk about stigma with our little kids, with our big kids, with our parents, with every single person, so they recognize that this stigma that we're talking about isn't real. We are all human. We are all different strokes for different folks. And once we start talking about how normal it is to be feeling different things through media, through films, through storytellings, then other people would feel more comfortable addressing it at work. And as Jeff beautifully stated, you can't help someone if you yourself need help, and everybody needs help from time to time. It's like when you're in an airplane, put the oxygen mask on first so that you can help others.
That's so interesting, Grishma, because some decades ago, when I started doing international travel, as a young person, I found those advisories very, very problematic. And only over time, I understood what point you're making. Those advisory for airline oxygen mask. That's fascinating. But I do want to say this, if I may, and get your response or other colleagues. Is it not? It's absolutely correct that one needs to be looking at one's own well-being and health, and care for the carers, as many of us say, is a critical aspect. But there's also the danger of, with all respect, following the Freudian model of having to be perfect internally, psychologically, before you help others. You don't want to do that also, right? I mean, I guess normalizing mental health experience of all news would be to say all of us, even those who provide help, might be going through problems as long as we seek sensible help. What would you say to that? And I have one more supplementary to that, but please, Grishma.
I'll pass the baton in just a moment, but I will have to say this. Lawyers need lawyers. Doctors need doctors.
Right,
dentists need dentists.
Sure.
Police officers need police officers.
And psychiatrists need psychiatrists and psychologists.
Exactly.
Sure.
So I'll leave it there. But I'd love to ask Dr. Kinger about this question as well. What are your thoughts?
My experience is that in India, we are taught to be empathetic. You are taught to kind of focus on the other person before you focus on yourself. So every time in a therapeutic session, when you say that, put the oxygen mask, we give the same analogy, people get very offended. They get, isn't that being selfish? So somewhere, I think, as Dr. Desai was saying, that, this whole, it makes sense to some people, and it actually disturbs a lot of people. So I agree that one size fits all doesn't really work in this context. Right. At the same time, when you clarify to people that, only when, you are in a good place, you can help other people, that creates the other dilemma as we were talking. They think that we are in a great place and that's why we are able to help them. Right. You don't want them to hero worship you and put you on a pedestal that this is a great guy who's going to solve all my problems. So it's a very tricky place to be in, that you're trying to make them see you as a human being. At the same time, you want them to see you as a service provider or a solution provider or a person who helps you on your journey towards better mental health or better life. So I think this is a very, very tricky.
If I might say, it seems to me at this minute that what we are talking about is optimal and appropriate attention to care for everyone.
Yes.
The clients, the family-based carers, professional carers, all of us, right?
Yes. Yes.
So the answer might be in optimal or appropriate care. Grishma, can we now switch, if you agree, to a slightly different platform about what's been said till now? You know, the stigma, the hesitancy in seeking help in everybody, including those who help. Would it be exaggerated to say, and I might again, Grishma, want your response first here, but from everyone, that the barriers or the obstacles to increasing access to mental health care largely come from stereotypes constructed in early development and in the society, and that gets sustained by, again, with all respect, the portrayal in the media?
It's definitely, in my opinion, a very huge way of doing things. You'll notice in the background, it's I think a police car. So it's very fitting with our panel. But yes, I do very much feel that the stories and the stereotypes are definitely increased with media and the other types of representation. But one other thing, and I think Dr. Nimesh left, okay. And one other thing that I did really think about is what are the ways that we as family members are also taking care of mental health needs. So, for example, Dr. Nimesh, you know, I'm a daughter, and you know, I'm also a psychologist, but I'm also a friend. So, if me personally, I'm going through a mental health crisis or an emergency of some kind, it's also going to affect my entire family. So how are we looking at, you know, the family unit as an asset-based unit? And how is that being shown in films and in media and in stories? We usually think that the people that know the answer are the doctors, but sometimes the parents know the family much more than the doctors ever can. So they need to be allies and advocates.
And so if I might request all three of our friends, Kishore, Narendra, and Jeff, to reflect on that in addition to the action-based programs that we have discussed till now, and there are many more in the US and India for sure, and across the globe. In addition to those action-based programs, is there really also a need to address the social stereotypes or the attitudes through mass media, through films, through awareness, and what have you? But how would each one of you respond to that, please?
Sir, can I go, sir?
Please, Kishore.
Yes. I think we have raised very, very important, at the same time, very difficult questions to answer. To start with, none of us are immune to develop a mental health problem. All of us can be affected. But at the same time, our professional training gives us the ability to deal with some of these problems by doing several things. You know, for example, self-care, physical activity, sharing your difficulties with your family members, then sharing your difficulties with your mentors, debriefing session that happens at very regular intervals. So debriefing is not just a disaster related phenomena that is to be considered. It happens in all places, particularly so with groups of people who work with vulnerable population. For example, the police department, the prison department, people who work with the homeless population. All three of them represent one of the most difficult area to work, for the simple reason that it often pushes us to a state of helplessness, because we are not able to find solution to many intractable problems that these people suffer from. So we have to understand that we are not omnipotent individual, that we have solutions to all the problems of the global community, that we also have limitations. And once we accept that and try to keep exploring problem solving as a method of increasing competence in professional life, because problems never stop by solving, let us say, 5 problems. After you have solved the 5th, you get on to the 6th, and it continues. So problem solving is part of our professional journey, and we should enjoy that rather than cursing ourselves, saying that, oh my God, this is terrible. I have to deal with these problems every day. So there is a small proverb in my local language. Having built a house in a shanty, don't cry that it is noisy. So we have to accept that there are problems. We learn to also take care of ourselves. Sharing is one of them, physical activity is one of them, diet is one of them, religious alienation is one of them, seeking help from God is one of them. So I find that all of these things helps me. And please remember that homeless population is one of the toughest areas in mental health to work with, because you have lot of cultural differences, you have lot of needs that you have to address, you have to put people into a particular kind of situation where they follow certain norms, and often they find it very difficult to follow those norms, and so on. So every day working with them is a challenge, coupled by the fact that you don't find people who are willing to accept them. You don't have organizations where you can refer them. So there is a constant battle between two people, which is very well established, the neurologist and the psychiatrist. Similarly, it is the psychiatry and the social welfare, because they hardly have any resource to support you, to accommodate hundreds and thousands of people who require care, but they don't have care, and your facilities are filled up, then you feel very, very helpless. But we have found a solution in the form of Home Again, where this can be addressed, but at the same time, it requires a lot of support, both from within the system, the general public. So in conclusion, professional training should help every one of us to deal with stresses of professional life. At the same time, accept that you have limitations, then that sense of omnipotence will go away and you will become realistic to solve problems.
Thank you, Kishore.
Dr.
It
Nimesh?
also prompts me to paraphrase the old saying about charity beginning at home, to say that destigmatization should begin within the mental health professional community first. And sadly, that's not how it happens. As many of us are saying, for reasons of their own intrapsychic factors and social stereotypes, those who are duty bound to help others and professionally trained to help others have a huge issue about stigma within their own community. Like I've been saying for years, how many psychiatrists or psychologists would accept within their team of having a bad day or a mental health issue? But in that sense, Narendra, Jeff, you had already referred to how policemen have this issue of what Kishore called as feeling omnipotent and the difficulty in accepting being, inverted commas, weak. We are also told that you did a large study on that. So would you please share very briefly the findings of that study, and do stereotypes operate? I'm kind of still there about stereotypes.
About the stereotypes, well, and just thinking, what's been said so far about, the stigma and the stereotypes. I think just my impression in the last few years, we've really done a lot to acknowledge those and bring those down. Where I see, given the volume of calls that we have for service, the amount of time and the major issue that this really is obviously in the world, but in our country and yours as well. Where I see the gap is in the funding. Everybody wants to do more. Everybody acknowledges that in the mental health field, we have to do more. We have to do more from a stereotype, from a services, and provide more. Where we hit an absolute brick wall is when it comes to resources and available, and that takes money. And we've walked away from our social responsibilities for several decades in this country, particularly in the urban poor, touching on the homelessness a little bit. But we still have a long way to go before people acknowledge that the answer is going to cost us some money here in terms of resources, and kind of putting your money where your mouth is, and getting those resources up and running and back to where they should be, with the volume of calls that we're dealing with. And kind of going back again to what Grishma was talking about with your family. We don't have enough time to get into every single little program that's being done, but it's interesting that, we really are looking at, when these calls come in, is a police officer the best person to respond to this? Should a police officer be the one in uniform with a gun and a badge, be the one going to help this person in crisis? Or should that be triaged a different way and go to a licensed clinician or a family member? There are some resources out there that specifically will trigger that sister being able to be called when there is a crisis, and avoid having an officer show up in the first place. So again, there's a lot of programs going on that, including close responder models with psychologists riding side by side with police officers. That's taking place in a lot of communities right now. So I think the stigma and the stereotypes, we're doing much better than we did 3 years ago. We have a long way to go, and we still have a ways to go for people to be committed to what it's really going to take to make things better.
Sure, and especially if you talk about Afro-Asian or the larger global context, Jeff, isn't that true? But what I like what you brought to the table about co-responder. Allow me to very briefly share what Kishore knows, and Kishore also mentioned what's happening in Tamil Nadu about the Emergency and Rescue Center. What the National Capital State of Delhi has for last few years as a pilot, and we hope to really upscale that by the end of this calendar year, is what you refer to as the co-responder model. If you have a mobile mental health team that works with the local police to rescue that person together, and so that both the teams can work together well. And my sense till now is that that works better than either the police team alone or the mental health team alone trying to rescue that person. We are here talking about, of course, the people with severe mental disorders. For people with common mental disorders and the first responders' own mental health, let me come back to you, Narendra. I also remember that you did that major study. In fact, Jeff came from ground level experience. You did that major study as was introduced. You want to briefly share what are those issues that police officers have?
So that study was done many years back. I've recently, in fact, our NGO has conducted a study with 200 police officers, which is at there's a local police station called Santa Cruz, where we interviewed and one-on-one interviews with 200 police officers. And what came across was that a lot of these police officers, instead of being worried about themselves, they were actually worried about the impact of their work on the family member. They found that the impact of the work that they do really impacted their own family, because when they were first responders, the family was and they were continuously on duty 24/7. And when the whole world was kind of being told to sit at home, these were the people to go there and be out there and be more physically present than they were ever before. So not only were they under tremendous stress, but they found that actually this has impacted their own family members. So during the first wave, we found that the policemen reported that their families were continuously making calls to them, checking out if they are okay, and whether they're going to be infected and things like that. The second thing that came up in this small study that we did was that during the second wave, the government introduced measures whereby the healthcare workers, police people, and all those who were really frontline were given the COVID injections first, so that the immunity improves. So actually, that kind of relieved the family, and they found that the families actually started feeling much more comfortable over the duty that they did. The third finding of that study was that a lot of police officers lost their life during this particular era or these 18 months. And recently, the government in Maharashtra actually declared that all officers who have lost their lives would be given some amount of money. So I think what has happened is that the government has taken certain steps which has kind of alleviated the anxiety for the families. So when I was talking to all of these officers, they were really concerned about the impact the work that they do will have on their children, on their parents, on their spouses. So largely the anxiety was not about preservation of the self. It was about the family unit and the family structure.
Thank you. Thanks so much. It seems that we have covered actually a huge ground across this panel with such diverse experience. But what would be our response to what Jeff has been saying more than once about resources being the issue? And let me be the devil's advocate here for a minute, largely out of conviction, partly or minimally to stimulate discussion. Jeff, my sense has been that the resource crunch is surely one issue, but even in pockets in India or across the globe where there isn't really resource crunch, the issue of stigma, the attitudinal barriers, and the access to mental health services does remain. And so it might be a little simplistic to say resource crunch is the major issue. Any response to that from any one of our friends?
Sir, can I come in, sir? Yes, sir. So the issue that Jeff has raised, a very, very important one, is making the police personnel vulnerable because they are the first responders. Is it necessary? Can somebody else be there? The answer is very, very difficult to say either in one sentence, yes, this is what it should be, because many a times mental health problems in such situations are mere challenging behaviors, either due to drug-induced behavior disturbances or severe emotional problems or other kinds of disturbances. And many of the crisis intervention teams, at least in the context of developing countries, at least I can say surely with India, that the crisis intervention teams are not trained to deal with such problems, and therefore police people are involved. While I would train in England, I have seen many situations where people are brought in a cage, handcuffed with chains because they think that we're very difficult to manage. Either it is stereotypes or it is to see that the person in custody is safely transitioned into the prison so that the legal liability is decreased. So there are many, many murky areas that should be addressed, and some of them can be addressed only by increasing the resources. That means more of mental health interventions becomes too complex. For example, an ischemic heart disease is dealt by an intervention cardiologist alone, whereas acute behavior disturbances had to be dealt with mental health professionals, law enforcing agencies, community leaders to protect their rights. So it becomes too very complex. Till we grapple with the situation, the nature of the problem is so that we will have to accept this situation, Jeff, unfortunately. Many a times mental health professionals are not supported by people. Like any serving people, like police officers or mental health professionals or other agencies are not supported adequately. Once I finish my job, I go home. I don't bother about what is happening to my colleague who is in the emergency room. So we will have to clearly develop a mechanism, at least with respect to mental health crisis, where mental health professionals, law enforcing agencies are involved periodic debriefing is going to be very important. The biggest unheard experience is that my distress is not legitimized by my boss. You're supposed to do this and you carry on doing it. Not all of us can do that. Therefore, creating a platform, creating a forum to legitimize a colleague's distress is a very important way of de-stressing that individual and pick up signs of stress in him so that the same thing can be addressed in a workplace. For example, if your colleague is snipping very often and is not completing his work tasks very easily, he is losing his temper, he is having difficulties, identify that and address him rather than leaving him alone. In some countries, this can be a very major problem. So these are the 3 areas where I think interventions can protect the first responder, be it a mental health professional, or be it a law enforcing agency, or be it community policing professionals. And we also know that there are a lot of volunteers who also work with the police personnel in some countries. But all said and done, we all have a professional hazard. During the COVID, I got infected with COVID, not because I wanted to. This is part of my job. I developed serious illness. I was hospitalized for 2 weeks. By God's grace, I came out. So if anyone thinks that you could have avoided that, there is no way I could have avoided that. As a doctor, I had to respond in a mental health, in a psychiatric institution. Having a COVID patient is a distant guess, but we still had it. At one time, a large number of people were infected. We had to deal with that because a collective response from the medical teams, mental health professionals, is the order of the day, and we should do it to the best of our ability. This is how I try to deal with the pandemic and the response to the pandemic with respect to mental health.
It's a lovely point that you just made about how, people are not going to get COVID, but it will or it can affect anybody. And the part about homelessness that you mentioned, it reminded me of a story that someone told me. While I was in my graduate program, I found out that there was another person that was doing their doctoral degree, and they were living out of their car because the program was so expensive. And being a teacher's assistant or a research assistant, you don't make that much. So they were basically living out of their car. They were very displaced at the moment. And that is one part of homelessness, being displaced. And the stereotype is that you have to be a certain way to be homeless. But here you have college students that are also homeless. And how does that affect people when something like COVID is happening, right? They are homeless, they are displaced. I think I heard about how there were hotels which were very empty, and they decided to open up certain hotel rooms to the homeless so that they have some places to go. And again, it goes back to family too, because if you are a person with a compromised system, maybe you've had cancer in the past, or maybe you're elderly or what have you, and you're not allowed to actually bring people from your family to your home, then of course you also have that segregation and that displacement as well. And Jeff, to your point, I'd love to come back to families just a little bit, because I think the theme here is that whether you're a police officer, you're still part of a family in law enforcement. Whether you're a child that's going through a mental health emergency of some kind, you're still part of a family that is also being impacted by that. So what are some things that you can share with us that families, whether professional or personal, can do to support those that are affected by mental health?
Well, let me tackle the first responder part of that first, because that's something that we've tried to do with different speakers that we've brought in over over time is invite the family too. This is what happened, this is what your husband, your wife, your significant other is going through, and maybe why they're acting, not sharing certain things and don't want to talk about other things with you at the dinner table or can't. So there's that part of it. The family thing, Grishma, I wish I had, again, a list of a playbook that we could just hand to everybody and say that this is, the resources that you have. We do have a number of county and local resources. Our victim services coordinator will meet with a number of these families and come up with a plan. Maybe the plan is not to call the police next time if we've been repeatedly going to it. Maybe the next time it's this number. And so those are kind of the ways that we're tackling, trying to think outside the box maybe a little bit, and instead of just putting notes on a call. Actually, how do we make sure that we're not coming back to this house for this reason because somebody's refusing to take their medications? That probably doesn't need to involve a police officer. There is no single change greater in my 23 years in law enforcement than that of mental health and how that's impacted the profession and the calls for service, both in volume and intensity. In terms of the patients and folks that we're dealing with. And we have to acknowledge the fact that this is a major, major issue and get as many people to the table as we can and understand how big of an impact this is having on services, on folks' day-to-day lives, and how much this is really touching everybody from a frequency and intensity standpoint. It's not going away, and it's only every year getting bigger and bigger and bigger.
Indeed, it is getting bigger. Oh, we've got another hand up. Dr.
Yeah.
Kumar?
Yeah. The point that I wanted to make is families, we know, are an important source of support for people with mental health problems, either giving them the medication or providing the support that is necessary. But in the present day context, families are themselves competing with each other to generate resource for the family, and therefore they're all busy. And the person who is neglected is the person with the mental health problem or any other disability. And you don't have an alternative system that is there. So we encounter a lot of families where neglecting the disabled is the predominant theme. People say, I can't take care of you, or it is not possible for me to do anything. So that element of sacrifice that all of us have experienced. I am what I am because my father and my mother sacrificed their life for me. And I have to do it for my daughter or my sisters or whatever that may be. So therefore, that element is changing. So what we see here is the change in the value system at the level of the family, at the level of the society, at the level of the larger system. There are economic value changes, political value changes, personal value changes. This is bringing out a very major crisis. What we thought families as a potential source to support disabled people in the past, it is gradually disappearing. So we have to come across, we have to bring in new ways of supporting these families. What are those ways? For example, we at the Banyan provide incentives for families to take care of mentally disabled people because alternative systems are lacking. We provide the transport allowance to see that they use the services very well. Wherever it is possible that the elders are there in their family, we provide home care as a rule to see that they are managed. At any given point in time, you may have to increase the resource allocation for vulnerable families in comparison to families who are living in the community. Suppose if all the things are there, the family expenditure may be about 2,000 rupees in Indian context. For vulnerable families, it may become 5,000 rupees, and we should be willing to shed that, or else they will become homeless. And this will reflect badly on the larger society. So therefore, a preventive strategy is to impart this kind of value education at the level of the school itself. Prepare the child to face the reality 20 years later or 30 years later, and it is bound to happen. We have seen the Western countries have gone round the clock and learned a new way of dealing with, but we are going through the same process, and we have come across such a terrible crisis with respect to supporting people who are disabled. So, school education, imparting education for the young people in the country to make them understand family responsibility, to empathize with disabled people, to empathize with the elderly, empathize with other people who are in need is one way forward to prepare the community, and so that you teach them the empathy, the value of caring, which will definitely come in the way of the crisis that we are going to face. Or else, if that kind of preparation does not happen, we are likely to face a very major crisis. With all the resource crunches that we have, it will be a very, very difficult situation to deal.
Thank you for sharing that. In one of my classes, I think Jeff, you were in this class with me. We were taught about the empathetic bridge, how you can react, which is more of what you're used to doing, or you can respond. And when you respond, then there's a form of empathy, which will help you find solutions that work for everybody. So that was from our teacher from Harvard, Dr. Marshall Gaines. Dr. Kinger, I'd like to come back to you. What are some of the solutions that families that are experiencing mental health emergencies, what are some things that they can do, in your opinion?
I think the starting point is acceptance that there's a mental health issue happening. Many times families live in denial. And as I said, in India, primarily it's about stigma. So trying to cover up. So I think as we become more and more open, we use media, we kind of, you spoke of films. My practical personal experience has been that there was a film which released over here where a young girl goes for therapy. And suddenly we found that a lot of people started accessing therapy. So I think media does really have a very, very important role to play over here. The other part, I think, is that young people are finding that they are more open to seeking these kind of solutions and help.
Yeah.
Dr. Kumar, can you please mute?
Oh, sorry.
So sorry about that. So I think young people, we are finding that people who are between 18 to 25 are more open to seeking mental health solutions and help. But sometimes they are kind of held back by their own families in terms of social disrepute it may bring, or their chances of getting a suitable partner in terms of marriage or the job situation and circumstances. I think as Kishorji was saying, I think the unit of the family has to be supportive, even for people who are having mental health issues. If somebody has cancer, or somebody has tuberculosis, or somebody has a heart attack, you find that 50 people land up at the hospital with bouquets, or and kind of mark their presence. But if somebody is having a mental health issue, people kind of don't even talk about it, and they want to talk about it in whispers. So I think the whole notion that this is something to be ashamed of has to be addressed first. It is like any other disorder, it's like any other disability, and people do become better. I think Dr. Nimesh and Dr. Kishore would be much more an expert over here. We have some phenomenal medications, we have some phenomenal strategies whereby people who go for medication, therapy, counseling, etc., can kind of rehabilitate back. So I think the idea is to work as a unit, support the client who's going through this, or a patient, as we call them, going through this, and get them to a better place. I think family support is very, very critical over here.
I think the movie you're talking about is Love You Zindagi.
Yes, my learning, Grishma and other friends, has been this, in line with what all of you have been saying. My learning has been that, as was said, I think we need to recognize that all across the globe, including traditionally family-based societies like India or South Asia, family systems or families are a double-edged sword. And it'll be a terrible mistake to believe that families are always supportive and always helpful. Denial, as Narendra brought out, is one issue. There are many others. That double-edged sword and the edge of the one edge of the double-edged sword getting sharper is only bringing the role of the state a lot more into the play. And so, unless we can really get state agencies to play their responsibility, we would be making the mistake of placing the burden on the families. And as friends have said, families cannot and do not now want to keep taking on that responsibility. But that, Grishma, also would bring me to how would films or other media, including social media, but at least films and the regular popular media, mass media, build alternate or counter narratives for the stigma, for the denial, for all the blocks that we have been talking about till now. You are in that unique position of being able to crystallize and share with us how much of that is happening and how do we do that better, building alternative narratives or counter narratives.
That's a really great point that you made. So there's used to be a saying, it used to be the victor gets to tell their story. So usually the victor is the person in power. And then you've got the people that are not in power that are called more often than not the oppressed. And so what happens is, even if you have stories that can be alternate narratives, the people that are in power don't want to hear these stories. And they don't want to listen to you because they have been told that if you look a certain way, if you talk a certain way, if you believe in certain things, if you love a certain way, then you are not worthy to have your story told. There is a movement going on, definitely. I feel it in Hollywood for sure with the projects that we're working on. I see it a little bit in Bollywood, but I think that the momentum still needs to be happening, where we are giving not because we want to give, but we recognize that when you tell the same story over and over and over again, it gets boring. And there are so many different stories out there in this world. And that's the only way that we're going to learn. So once we start to recognize that at the top rather than at the bottom, then we're starting to start seeing different alternatives, because they still need to be funded. They still need to be green lit. And who are those people that are going to be green lighting millions and millions of dollars worth of projects? They're usually the ones that have the privilege, and they may not look like us. So it's all about getting to the seat, getting to that table, opening those doors. Like me, I'm an amputee. I'm an entertainment psychologist. I'm 5 feet nothing. Would people listen to me? Probably not. But now maybe some people will listen to me because I've got the credentials and, I've got a really good mentor team that says, yeah, you have some really great points. So I know we're very, wrapped for time, but I'd love to just summarize this. And I'll start with you, Dr. Nimesh. What are some amazing points that you got out of this panel? And then I'll share my own.
Sure, Grishma. Thanks so much. Let's do that. If all of you would agree, I'll try and summarize it this way. It would seem that one of the major challenges in the post-COVID era that existed earlier, but it's only going to get bigger, is increasing access to mental health that seems to suffer from a huge gap. The contributing factors are far too many. And it would seem at almost every level of human existence. And so the efforts to increase or enhance access will also have to be that broad-based a spectrum of strategies or programs. We recapitulated some very good action programs. We spoke about how families and societies contribute. We spoke about how films and mass media can help. But it does seem to me that we do have a huge mountain to cross as humanity to really get neutral, non-stigmatized, increased access to mental health. And that should require a huge bucket list, so to say. That wish list will include many things that people have said. More action programs for different categories of persons in need of help, more awareness campaigns, more family and value-based education, more responsibility of the state being executed, alternative or counter narratives from films and the other media. Can I also say that what we all have at heart in this session, and it may be helpful to crystallize, that in the context of the National Ability Summit 2.0 that we are doing in 2021 with Varija and Grishma at the lead, is the fact, it would seem to me, axiomatic, that persons with mental health problems, the full range of mental health problems, but certainly the people with moderate to severe mental health problems, really do not have an opportunity to get to their abilities being demonstrated or established, mainly because of the lack of access or utilization of mental health services. And so it would seem that at least in terms of mental illness or mental health problem related disability, the idea of empowerment or enabling would have the first requisite step of increasing access to and utilization of mental health services. Grishma, all yours. If you and the other colleagues would like to see how you can put that better or improve upon that, please.
Thank you, Dr. Nimesh. What I always tell people is, how many of us wear contacts or glasses? I'm going to raise my hand. Anyone here? I've got Dr. Kumar that wears glasses, Dr. Kinger that wears glasses. What about you, Jeff? Perfect vision? Wow. Okay. So now think about that. Jeff is the only person that has perfect vision. So when you wake up in the morning and you don't have your glasses on and you don't have your contacts on, you're not going to be able to drive. You're not going to be able to operate. You're not going to be able to cook. But technology did this beautiful thing, creating glasses for us and contacts for us, which allows us to be able to navigate our world. So it's about the infrastructure. And the other thing I want to say is, you know, in India, a lot of people have diabetes. In India, a lot of people have diabetes. And even if you're not in India, you're living abroad, a lot of people that I know that are South Asian have diabetes. So if diabetes isn't considered a bad thing, it's considered a thing. Why is mental health considered a bad thing and not just a thing? So it's all about how we're shaping these narratives and shaping these stories. I don't have too many people that I know that say, yeah, you know, I have a really bad disability. I have diabetes. They usually say, yeah, I have diabetes and I take care of it. And that's how it should be for everything, even a mental health need. And then finally, about families, I think you're absolutely right. You know, we really need to find a balance between how much burden we're putting onto families and how they can be our assets. But without the services that are provided for us, because of the governments and because of other centers nearby, it really needs to be a shared effort.
Can I also say, Grishma, if I may please add, that what Narendra referred to is, in addition to what you just now said, is the fact that the science in mental health, not just in biomedical or neurosciences, but the science in behavioral sector and the social sector, all sciences put together, has huge set of solutions to offer, and yet that benefit is not accruing to persons with mental health problems or larger society. And so, as many of us have felt, this pandemic and the post-pandemic situation is the opportunity for us to seize, to keep mental health at center stage and get the science to benefit large sections of humanity in mental well-being context.
Karishma, can I make a point?
Sure, please.
Yes.
The only film that was able to capture the reality of mental illness is Beautiful Mind. I think there is a lot of barriers that exist in transforming an experience which is closer to the reality of mental illness on the silver screen. And once we are able to do this, a large number of people can be educated. For example, in the early 50s, tuberculosis was very well captured, leprosy was very well captured. But for the last 75 years, we are not being able to capture mental illness so that people can understand, because many people who have conducted what is called as health valuation research have demonstrated that experience of mental health problem is closer to death. But unfortunately, that is not reflected in the policies and programs of the government. Secondly, depending on the government is not the end of it. Families have to play a very important role. But families have to be trained in the today's context of changing modern values, economic values, familial values, social values. Teaching families the ability to care is an important way forward, because that is the only permanent resource. No government is a permanent resource, no agency is a permanent resource once we build that. So where do we start? This building up process should start from schools, start from adolescent education, which can transform people into better human beings, one, and also caring human beings too, so that tomorrow we have a big social capital for caring for the disabled in our society.
Okay, so Grishma, with a big thank you to Jeff and Narendra and Kishore on behalf of yourself and my own part, as well as the NAS team. Can I just say in the end that we need to perhaps actualize and implement the maxim that mental health is everybody's business.